All right, so we'll start with the first case. This is a 70-year-old gentleman who came in with generalized weakness, dizziness, and gait issues. Has a past medical history of diabetes, hypertension, coronary artery disease, and substance abuse. On exam, notable for right homonymous hemianopsia, had diffuse weakness and poor effort on exam, but most notably had 2 out of 5 weakness in the right lower extremity. No clear sensory issues. So this is the scan. Let's see who's here. Connor, you want to describe the scan here?
Sure. It appears to be a rig enhancing lesion on an MRI T2. Also, there's edema. There's edema on flare shown in the left occipital lobe, as well as let's see, some central necrosis possibly.
So you're saying edema on the flare. So this one here is what you're saying.
Correct.
The edema.
Yes.
Okay. And then this is a diffusion sequence. Do you see anything there?
Diffusion sequence. It does not appear to be associated with a major vessel by location. Diffusion sequence, unsure.
Yeah, so I don't see any real, no significant diffusion restriction there. This is a non-contrast T1, and these are the contrast images. So you would say a ring enhancing lesion, which I think you said. So just to sum it up, ring enhancing lesion with surrounding edema. A couple more things. How would you describe the ring enhancement, like the thickness, the irregularity? Where on the spectrum of ring enhancement would you classify this?
Very, very thick and coronal, especially on post contrast. And irregular, more almost near the dura. It is thicker.
And what kind of, how does the thickness or irregularity of the enhancement help you figure out what this might be? We can maybe bring in Turkey. You want to chime in?
Hey, Silva. Sorry, can you repeat the question?
So this is a 70-year-old guy who came in with generalized weakness and right lower extremity weakness and a right homonymous hemianopsia. He's got this this imaging, and we were just talking about the appearance of the ring enhancement and how that would kind of help guide you towards a differential diagnosis.
Yeah. So given that ring enhancement has a couple of differential diagnosis. One can be glioblastoma. It can be subacute ICH that is resolving, or it can be multiple sclerosis.
What are the 3 most common things that would present as a ring enhancing lesion?
The most common thing is glioblastoma.
And there's 2 more that are commonly ring enhancing.
Abscess, and also abscess. Yeah, and can be metastatic disease too.
Yep. And do you think this is an abscess? There's a diffusion sequence, the second image on the top.
No, it does not look like an abscess to me.
Okay, perfect. Okay, so you want to just sum this up, like briefly, how would you describe this lesion, and then give kind of your top 3 choices of what this might be?
Yeah, so this is a ring enhancing lesion, as you said. It's in the left parietal area with vasogenic edema. It's in the almost medial left parietal. It looks like, given his history, more of either glioblastoma, or it could be a metastatic disease.
Good. That's perfect. And then last thing, do you think this is in front or behind motor? I mean, you suggested it, but where do you think it is, and why did you say that?
Yeah, because if you compare it to the other side, you can see the motor strip, and this is displacing more than being a primary motor lesion. So I think this is a more of a posterior frontal parietal that is displacing the motor cortex.
Yeah, I think you were right. Initially, parietal lesion, you look at the other side, try to identify the motor strip, but on just these slices, that's the best way to do it. Perfect. So differential, you kind of went through it very nicely. There was some other workup done to look for metastatic disease. There was a left upper lobe mass on the CT of the lungs, nothing crazy in the labs. So what would you do for this, Turkey? Turkey, I think you're muted.
Sorry, Selva, are you asking me?
Yes. What would you do for this?
Yeah, so for this lesion, it needs to be taken out for sure and needs to be biopsied for diagnosis. So I would, offer surgery for this patient. And of course, I would make sure that it's not a metastatic disease. Therefore, I would do CT chest, abdomen, pelvis.
Which has been done.
Yeah.
So CT of the lung has a left upper lobe mass. Why wouldn't you just have them biopsy the lung mass and just leave the brain lesion?
Yeah, because it's causing, it has a very large vasogenic edema, it's causing symptoms, and it's going to get bigger and bigger. So this has to be, taken out. And it's also going to guide diagnosis. So I would offer surgery for this patient, given that it's on the left side. I would offer awake brain tumor resection.
Okay, perfect. So I agree with resection, and that is what was done. So we'll move to the neuropathology slides.
Okay, thank you. So here in the center of the field, you can see that there is squamous epithelium, and the clear cells are actually keratinocytes. Next slide, please. And here we see cartilage. So you have two embryonic layers. You have the squamous epithelium, and then you have cartilage, and you can see nests of poorly differentiated or undifferentiated tumor cells, the ones that are blue, hyperchromatic, with very, very scant cytoplasm. Yes, thank you. And next slide. And this is the bulk of the tumor. This tumor is as similar to the previous nests. It's poorly differentiated or undifferentiated. It has no particular growth pattern. So this is what we call blue cell undifferentiated neoplasm. Thank you. And this is higher magnification. To the right, there is a rosette, which can be seen in this type of tumor. So this is a malignant tumor. Next slide, please. This is CD56, which is a neuronal marker. So there is neuroendocrine differentiation in this tumor. And so this is a Wilms tumor arising within immature teratoma. So for all practical purposes, this is immature teratoma of the CNS.
So not a common thing that we see, obviously. So I'll go through a little bit of background. So Wilms tumor or nephroblastoma, it's a common renal tumor in children and occurs only very rarely in adults. They're usually heterogeneous solid masses that can have a cystic component. And they do have the ability to metastasize to the lung, liver, or IVC. Very rarely they can metastasize to the brain. But what we have here is a very different entity, which is that they can occur extrarenal, but arising from other neoplasms, in particular a teratoma. So this being an immature, poorly differentiated teratoma, as Dr. Saad said, has cells from different lineages. So there's this histology, this triphasic histology. You get epithelial, stromal, and blasternal components on histology, and then the Wilms tumor actually, in this case, arose from that immature teratoma. The teratoma itself, again, some background, it's a germ cell tumor commonly, again, seen in children, usually during adolescence. Common locations for teratomas can be pineal or suprasellar. And some markers that are suggestive of teratomas are elevated AFP and CEA. And as Dr. Sada was saying, they have cells from at least 2 of either ectoderm, mesoderm, or endoderm, and they can be very heterogeneous, as we saw evidence of cartilage, keratin components. So they can have fat calcification, fibrosis, and cystic components as well. And they can be classified as either immature, mature, or immature with malignant features. In this case, it was immature, and it was from this immature and poorly differentiated tissue that the Wilms tumor is thought to have arisen, and that was a diagnosis in this case. Obviously, not something we see commonly, but something to keep in mind. Right. So we'll move on to the second case here. Let's see. Long, do you want to, actually Ahmad, are you there?
Yeah, I'm here.
All right, so this is a 58-year-old homeless female. She was found on the street actively seizing with right hemibody rhythmic movements, also noted to have a right facial droop. She was admitted to the ICU, found to be in focal status that required a Versed drip to control. Past medical history notable for alcohol use disorder. And as I mentioned, she was homeless. So on exam, again, she's on a Versed drip, a little bit sedated, but her eyes are open. She follows weakly on the left side, but very minimally. And the right hemibody did not show any movement. There are her labs as well, slight bump in the LFTs. So do you want to describe the imaging here? And just for guidance, on the top, it's a T1 flare and a T2. Bottom is contrast with contrast T1.
Yeah, so she has some extensive left-sided vasogenic edema. She also has a irregularly enhancing mass in the left frontal parietal region. It's
Frontal or parietal?
Let's see, more frontal.
Yes. Good. So
Some
you
irregular
said a
enhancement.
couple of things: edema, enhancement in the frontal lobe. I agree with all of that. Kind of irregularly enhancing, as you said. Yeah, I think you hit it all. So based on this this imaging, what are some things that you would consider on the differential?
Yeah, I think with this much edema, irregular enhancement, could be metastatic disease. I think that's like one of the first things I think about. Could also be like a primary CNS tumor, even like a GBM because of the irregular enhancement, or those are the first two things I'm really thinking about. Really along the lines of oncologic etiologies.
So you mentioned neoplasms, but how about anything that's not necessarily neoplastic?
Could also maybe be infectious also. I mean, she's homeless, and like she's probably high risk for some infectious etiologies. Could be like maybe like less likely to be an abscess because of the enhanced pattern, but could be something like maybe toxo if she's like HIV positive. But that's also probably like a lower on my differential, but still something on there.
Good. I think you hit all of the big ones, and then I think one more category that I would include there is maybe can you think of any, like another big category of CNS lesions that you can see? So not neoplastic and not infectious. Maybe think of a young female with new neurologic deficits.
Neurological, like are we thinking like
thinking like an inflammatory or
like MS
along
or
those
like,
lines? Like exactly,
yeah,
exactly. We can sometimes have a tumor-like appearance.
Gotcha. Oh, okay, cool.
So I think you really hit everything. So primary CNS neoplasm, metastasis, this whole bucket of infectious pathologies, and especially like you said, maybe given the social history, maybe she does have some immune suppression, and then tumefactive multiple sclerosis is one thing I would add. All right, so we have some new lab results. So HIV panel is positive. You had alluded to that maybe being a possibility. CD4 count is low, and the CMV viral load in the blood was elevated. What do you think of the CSF there?
CSF doesn't really look infectious, but it could be something like more of not like a bacterial infection, but maybe something like a viral, because of the higher protein. Glucose is kind of high, but like not. I would expect it to be lower if you're thinking about like infectious, like in terms of bacterial infection or something like that.
I agree. Perfect. Yeah. So it's not perfectly normal, but looks pretty good. Probably not, bacterial meningitis. You're right. So what would you want to do for this? I'll go back to the scan.
For her, probably start her steroids just because of given the amount of vasogenic edema. I think probably at least
what's one reason that you may not want to give steroids to this patient? If we go to our differential, what's something on here? Not necessarily that was done in this case, but just for the exercise, is there anything on this differential that would maybe lead you not to give steroids quite yet? Victor Liu?
Sure.
Lymphoma?
Yeah, exactly. So Ahmad, giving steroids in a patient in whom you suspect lymphoma can decrease the diagnostic yield if you were going to do a biopsy or some sort of resection for it. So oftentimes we'll hold back on steroids until, if we have a high suspicion for lymphoma. So yeah, I agree. I mean, you need tissue for diagnosis in this case. So that's what was done, and it was taken out. So we'll go to the neuropathology slides with Dr. Saad.
Okay, so this is a low magnification view of the lesion. First of all, this is a hypercellular brain tissue, and you can see scattered lymphocytic infiltrates. So all these round hyperchromatic cells are lymphocytes. Next slide, please. In other areas, there was extensive necrosis, as illustrated in this particular image. There is a little bit of hemorrhage at the bottom of the image, and then the rest of it is completely necrotic. Next slide. And CMV, here I'm showing you two images showing some cells that are CMV positive. So we call this CMV encephalitis. I believe this is the last slide. Next case, next slide. Toxoplasma was equivocal because of the necrosis. Necrotic cells pick up the stain, so it makes it very difficult and challenging to determine whether it is positive in reality or just false positivity. So we called it equivocal, and we recommended additional studies. So CMV encephalitis, and as you guys mentioned, I did the GMS, which is a fungal stain, AFB, herpes type 1, herpes type 2, spirochetes, SV40, which is the agent for PML. They all came back negative.
So CMV encephalitis is the diagnosis in this case. Very common most common in immunocompromised patients, especially with the CD4 count less than 50. This patient's CD4 count was, I think, 58. On imaging, common to have white matter and flare changes, as we saw in this patient, and radiographically can be similar to PML, lymphoma, or HIV encephalitis. So really, the lab testing is important for the diagnosis and the histology that we saw. Interestingly, the CSF in this patient did not come back, the PCR did not come back positive for CMV, but the sensitivity is only 82%. So this is a case that would fall into the category that was not picked up on CSF PCR. The histology, as Dr. Saad went through, common to have necrosis, as we saw in the previous slides with that area of hemorrhage and necrosis. Commonly, there are intranuclear inclusions with clear halo around them, and the CMV immunostain is really critical for the diagnosis. Treatment with, again, cyclovir and foscarnet Patient now has recovered significantly neurologically and continues on the antivirals. So I think Ahmad, you did a good job kind of pinning down the differential, and it turned out to be infectious in this patient. Next case, Long. This one will be for you. 62-year-old with hypertension, metastatic breast cancer, and multiple myeloma. She comes in with acute worsening of her chronic back pain. Following this back pain, she developed numbness in her lower extremities, and then the following day developed weakness, pretty profound weakness. No changes in her urinary or bowel habits. Past medical history, as I mentioned, metastatic breast cancer, currently on chemotherapy, also with myeloma, multiple myeloma, also being treated currently. On exam, weakness in the bilateral lower extremities, most notably in the hip flexors, 2 out of 5 in the bilateral hip flexors. Decreased sensation to light touch, starting just above the umbilicus. No clonus or Hoffman's. Her platelet count 48, and we did a CT of the abdomen showing diffuse intra-abdominal and bony metastases. So Long, based on just the story and the exam, what are some things that are going through your mind, and where might you want to look with your imaging?
Yeah, so I mean, this is an elderly female patient with a significant cancer history, primarily breast cancer and multiple myeloma, both of which are known to metastasize to the bone. So in a patient that's developed new neurologic deficit with this cancer history, I would be most concerned for that.
And based on this exam, where might you, like, before looking at any imaging, what would be the area of the spine that you'd be most concerned about?
Yeah, so so she has decreased sensation to light touch starting just above the umbilicus. So at that level, I would most suspect around lower thoracic, around T10.
Good. Yeah. So I think that's a good thought. So we'll go to the imaging. This is the CT. You want to just quickly describe the CT before we go to the MRI? Long, I think you're on mute.
Sorry. Yeah. So I see. So CT of the thoracic spine, sagittal and axial sequence. There's a compression fracture. One of the probably mid to lower thoracic vertebra.
All right. So let's go to the MRI. What do you see here?
It looks like there's what appears to be diffuse, bony involvement of the metastatic disease, as well as what looks like maybe a extramedullary intradural lesion.
Why do you say intradural? Let's first identify what sequences these are. So from left to right, what MRI sequences are we looking at?
Yeah, so on the left, looks like a T1.
Yep.
In the middle, looks like a T2, and then on the right, I think that's a T1 with contrast.
Yeah, exactly. Yeah. So why is this intradural?
Actually, actually, I'm not entirely sure if it's intradural. After further review, maybe it's probably extramedullary extradural lesion.
And what makes you think that?
I don't see I don't see really a, on the T2 sequence, it doesn't look like it's really arising from the dura itself. I don't see any significant, like it's compressing the, it looks like it's extending and compressing into the CSF space.
So what's CSF on T1 and T2? What intensity?
Yeah, so on T2, CSF is hyper intense. On T1, CSF is hypo intense.
Exactly, yeah. So do you see the CSF space being compressed externally on the T1 and T2, or what would you say?
Yeah, I think it looks like it's being compressed externally.
Yeah, exactly. I mean, I think you're thinking about the right way. You see the T2 signal, and then you kind of see this tapering of it being compressed outside the dura. So I think I agree. I think this is extradural as well. And contrast enhancing or no?
Yeah, it does. The lesion does appear to be contrast enhancing on the T1 with contrast.
Yeah, I agree. Okay. Is there anything else you'd want to look at? Any other imaging or any other studies?
You said there was already a CT chest abdomen pelvis, which just showed diffuse, diffuse involvement of the diffuse bony involvement and intra-abdominal mets, right?
Exactly, yeah. So she's got diffuse intra-abdominal bony mets. So we've done that. So yeah. What would your differential be? So you said already it's an extradural lesion. What are things that you would think of for an extradural spinal lesion?
Yeah, so I guess this patient with this significant cancer history, at the top of my differential would be breast cancer met. She also has a history of multiple myeloma as well. Multiple myeloma would also be on my differential. I'm not, I would say like lower on my differential would be some type of infectious etiology, like like an abscess. I'm not sure if she presented with like an elevated white counter fevers, but right now I would say that'll probably be lower on my differential. I think that would be primarily.
What if it's a primary tumor of the area instead of a tumor from somewhere else? What would you think a primary tumor of this area might be? Think about what lives outside the dura.
I mean, like primary, I guess spine tumors that would be extradural, or potentially like any tumors arising from the bone.
Exactly. Yeah, that's perfect. So, yeah, just think, geographically where this is, and outside the dura is the bone. So things for epidural spinal lesion. So any primary bone tumor, osteoblastoma, osteoid osteoma, aneurysmal bone cyst. The metastasis, as you mentioned, the patient has two primary, cancers that are active. Hematologic malignancy, myeloma, lymphoma, or like you said, lower on the differential, an infectious etiology. This patient didn't have any infectious signs at all. So what would you do for this lesion? I'll go back to the imaging.
So, I think given her acute neurologic change, I think a laminectomy for decompression, as well as a tumor resection for tissue sampling and biopsy, would probably be my plan for this patient.
Okay, and do you think you need a fusion in this patient?
Excuse me, sorry. The question was, I don't think I need a fusion. I think just one like laminectomy would be fine.
Adam, do you want to tell us like why, in what circumstances would you need to do a fusion on this patient after surgery or in surgery?
Hey, so sorry, I didn't hear your question.
We were talking about the surgery for this patient, so long recommended surgery. We're talking about whether or not you would need to do a fusion for this patient. What do you think, and in what circumstances would you want to or need to?
I would do only like a two level LAMI and tumor resection. I think it's a thoracic. I think the alignment looks good. I don't think you would need to fuse any part of this part. Yeah, as patient has also one compression, one compressed vertebra down below, but I also wouldn't do anything for that. Maybe in the long process, if the patient's complaining of anything, maybe a one level kyphoplasty. But I don't
first of
think
all, how would you assess the alignment of this patient? Do you think the MRI is a good study for that?
No, I think we need to go back to the initial CT that you showed, and then we can assess based on that.
Is a CT a good study for alignment? What position is the patient in for a CT scan or an MRI?
Sorry, what?
When a patient gets a CT or an MRI, what position are they in?
They're laying flat, so we need to get X-rays.
Yeah, exactly. So just a little aside, right? If you're going to check for the alignment, they need to be upright X-rays to assess for alignment, because when a patient's laying flat, you're not going to appreciate their alignment. But for this case in particular, what about the tumor and the tumor's appearance on the imaging might suggest that you would need to fuse the patient in the surgery?
If it's arising from the pedicles, if there's disruption of the joints,
Damien, do you want to chime in?
So sorry, what was the question?
We're talking about the surgery for this patient, and in what circumstances you would think you'd need a fusion.
Yeah, I mean, it looks like the tumor is like obliterating the pedicle on the right side there. So I mean, to take this out, you come transpedicular and you go through the pedicle anyway. So this is probably something that would need a fusion in this case, because you're going to risk, or you will destabilize the patient by doing a pretty extensive tumor resection at that level. It also looks like he is a little bit kyphotic at that level, kind of like right above it. So I think that he would probably need a fusion. You're going to take out the bulk of that tumor, not all of it.
Yeah, so exactly. So if the tumor resection itself is going to destabilize the patient, that would be a scenario when a fusion would be needed. So we went to the differential. What was done was a T5 to 8 laminectomy for resection of the tumor. In this case, an in situ fusion was done. The patient obviously required a platelet transfusion because of their platelets of 48. And then the intra-abdominal lesions were also biopsied by IR. So from here, we'll go to the neuropathology slides.
Okay, thank you. So this is the tumor. As you can see, it's very cellular and consists of sheets of neoplastic cells. Next slide, please. And this is higher magnification. You can see, especially in the center of the field, scattered mitosis, 2 or 3 mitoses, and the cells have this plasmacytoid appearance, meaning large cytoplasm, prominent nucleolus, and slightly clear or partially clear cytoplasm. Next slide. This is CD138, which is a specific plasma cell marker. As you can see, it is diffusely positive. Next slide. And also by in situ hybridization, the tumor cells are lambda restricted. So this is a monoclonal plasma cell neoplasm. Next slide. So this is a plasma cell myeloma, straightforward case.
So the pathology report mentioned that there were anaplastic features on this. Is that something we can tell from this, or is not quite?
Yes, unfortunately, I don't have the arrow, but let me see. So if you go to the bottom of the picture, there are cells. No, could you go back? The bottom of the picture, there are cells. Yeah, very prominent nucleoli. Could you go back? Go back, please, to the other picture.
The zoomed in here.
Yeah, this one.
Okay.
Yeah, exactly. It was very close to the arrow.
Let me see if I can.
Yeah, exactly. This one. Yeah. So these are almost myeloma cells. So these are the anaplastic cells that that Dr. Chapman reported commented on.
Okay, thanks. So multiple myeloma or plasmacytoma, if it's only a single lesion, it's the most common bone neoplasm in adults and arises from monoclonal proliferation of plasma cells. And as Dr. Saad said, it's monoclonal, literally comes from one lineage. And they can present with lytic bone lesions or compression fractures, as we saw in this patient, separate from the tumor itself. Lab findings, you can see Ig light chain proteinuria, Bence-Jones proteinuria, as well as monoclonal gammopathy and protein electrophoresis. Other systemic signs, these patients can present with anemia, renal insufficiency, and hypercalcemia, all related to this marrow invasion and monoclonal proliferation of plasma cells. Treatment is with protease inhibitors, steroids, and immune modulators. So in this case, there were anaplastic features in the report. So anaplastic transformation has a very poor prognosis for these patients, even though myeloma has a reasonable prognosis without anaplastic features. Typically, the anaplastic myeloma is an IgA gammopathy, and on histology, you get more pleomorphic cells, multinucleated, and as we saw, the prominent nucleoli that Dr. Saad was mentioning, and these can present with more soft tissue masses as well. There are a couple of case reports of epidural multiple myeloma, and this seemed to have arisen invaded locally from the bone there. So we'll go to the last case here. So this is a 29-year-old with a history of pleomorphic xanthorastrocytoma that had been resected twice, also had undergone chemotherapy and radiation and shunt placement. She came in with 3 weeks of progressive difficulty ambulating, now unable to move her legs at all, no urinary changes. She her medications she's on chemotherapy actively for this tumor, as well as steroids and Keppra. So on exam, she has at baseline, due to her intracranial pathology, right homonymous hemianopsia, aphasia, and a subtle right facial droop, as well as right upper extremity weakness. These are all baseline. What's new is this nuance at 0 to 5 strength in the bilateral lower extremities, as well as hyperreflexia and decreased sensation in the lower extremities. So let me see, who else is here? Sumed, you want to chime in on this and maybe say what's concerning or where you would want to look in this patient, given that history?
Hey, for sure. So this patient has lower extremity strength at 0s. So the first thing, and given her prior cancer history, I'd be concerned of like a low thoracic, high lumbar lesion that's probably compressing either conus or like the cord. Just given that hyperreflexia right there, I'd also say it's probably less likely to be lower than that. However, I'd want to image the thoracic and lumbar spine with MRI with and without.
Okay, good. So here's the imaging. You want to describe what you see?
Yeah. So on we see here at on the just going from like right to left. We're looking at a T1 with contrast showing what looks to be, this one looks like an intradural, potentially extramedullary mass arising around T6. You don't really see a significant amount of T1 signal just by itself. And then you see a little bit of an outline on the T2 over there. So I'm thinking this is an intradural extramedullary lesion arising around T6, given her cancer history of pleomorphic xanthorastrocytoma. I think that this is someone who will needs resection, given the just for tissue diagnosis, but also needs needs a decompression and removal of tumor.
How does the cord look?
The cord actually looks very looks indented at that level, so that's another concern right there. It looks like you can see a almost like a cleft around the around the mass, and the cord looks like it's being indented. And then maybe around T4-5, you can see a little bit of hyperintensity in the cord, even a little bit lower than that as well. So you could argue that there is some cord signal change associated with this lesion.
See on the axial as well.
Yeah.
So I agree with all of that. So we also got some cervical spine imaging. What do you see here?
Yeah, cervical spine. Similarly, I'm seeing another lesion centered around C5-6, and it has a very similar characteristic as the thoracic lesion as well. Indentation of the spinal cord with this intradural extramedullary mass, and similarly some cord signal change associated with that on the axials and everything. Do we have any prior imaging for this lady? Because she has a baseline cancer. She has a baseline history of upper extremity weakness.
Yeah, no prior imaging. Yeah, no prior imaging. So
Gotcha.
Do you think the symptoms are coming from this lesion, the thoracic lesion? Unclear.
I think this is coming from most likely the thoracic lesion, only because her lower extremities are out, and then if we have like baseline upper extremity weakness itself, the only thing that has changed is her lower extremities, then I would say that this is most likely a thoracic lesion.
Yeah, so the new symptoms are lower extremity. Even though this looks horrible, it's probably the thoracic lesion that's causing her acute symptoms. And then just for review about the imaging here, just compare this, especially for the interns that we were talking about earlier, the other lesion. Look at the CSF signal and the location of the tumor relative to the cord. And then I'll quickly go back to this MRI, and you can see on the T2, the CSF signal kind of tapers off at the location of the tumor, with this being an extradural lesion. Whereas here, that space is, you almost see more CSF signal because it's in that CSF space. So kind of good comparison there to identify on T2 an extradural versus an intradural lesion. So there's some intracranial imaging as well, which I won't harp on, but there's obviously evidence of prior resection, as well as some small residual tumors in different locations. So Sumedh, what would your differential for this be?
Yeah, differential for this would be like the metastasis of her known pleomorphic xanthro. It could also be de novo lesions, intradural extramedullary masses, include things like ependymomas, though unlikely at this lesion, unlikely at this level here. And what it looks like, it could also be meningioma. Those would be the primary differential for someone like this. And then infectious would be less likely. I don't think that would be the case for this one. So I'd say like tumor, most likely metastasis of known intracranial lesions.
Anything else intradural extramedullary? That's like one category. Not that this looks like that, but anything else comes to mind? What if I showed you a CT with an expanded foramen on one side?
Oh yeah, I mean it could be like a neurofibroma or Schwann, peripheral Schwann. Exactly.
So that's most of it: meningioma, schwannoma, neurofibroma, and MET being at the top of the list. So what would you do for this patient's multiple tumors?
I think that given that the most symptomatic lesion is a thoracic one, you'd probably just want to laminectomize and then intradurally remove the thoracic lesion for tissue diagnosis and decompression. And then, if it's something that can be targeted with radiation or other targetable therapies, and we would proceed with those for the thoracic, for the thoracic as well, but also for the cervical lesion.
Yeah, I agree. I think we talked about, which lesion is symptomatic, and we agree that it's the thoracic one that's causing new symptoms. So, she's acutely paraplegic, and I agree. That's what should be targeted. And that's what was done at T5-6 LAMI with resection of the tumor, and then followed by adjuvant therapy. So we'll go to the neuropathology now, Dr. Saad.
Okay, thank you. So this is the tumor. Here you can see what we call significant atypia and pleomorphism, meaning the tumor cells are variable in size and shape, with some cells having irregular nuclear contour and hyperchromasia. Next slide, please. And this is the significant pleomorphism that we mentioned in the report. We did pleomorphic high-grade astrocytoma based on the presence. There is one in the center of the image, which is has this vacuolated large nucleus with very scant cytoplasm. So that's a typical pleomorphic cell. And to the right, you can see a peripheral nerve. This is just incidental finding. Next slide. Ki67, which is a proliferation marker, is very high for an astrocytoma. So this is about, I would say, 7 to 10%. That's pretty high. And next slide. This is OLIC2, which is a pan-glial neoplasm. It shows some tumor cells that are positive, which indicates this is indeed a glioma that appears to be high grade. And next slide. BRAF. Remember that BRAF mutation is seen in pleomorphic xanthoastrocytoma, and it was seen in this particular tumor as well. And next slide. So we called it pleomorphic glioma because the histologic features of PXA were lacking. However, the history of PXA and the BRAF mutation support the impression that this most likely represent a metastatic PXA with progression toward higher grade.
Thanks, Dr. Saad. So pleomorphic xanthoastrocytoma, common in younger patients, age 10 to 30 is where the peak incidence is. Commonly present initially in the temporal lobe with seizures. That's the classic story that you'll hear on boards, and often cortically located abutting the dura. As was mentioned, cystic and avidly enhancing, and they may actually have a react because of the location near the dura. You see some examples, an example at the top right, may have a reactive dural tail with adjacent bone remodeling. WHO grade 2 or 3, and grade 3, as in this case, meaning anaplastic with more mitoses, more necrosis, and vascular proliferation. These tumors are GFAP positive, S100 positive, and the histology, as Dr. Saad mentioned, is pleomorphic, hence the name pleomorphic xanthoastrocytoma. So they have xanthomatous, fat-filled astrocytes. We saw a good example on Dr. Saad's histology slides. Hyperchromatic atypical nuclea with inclusions, and these multinucleated cells and spindle cells. So there are some case reports of leptomeningeal spread of anaplastic PXA, and these unfortunately are usually not responsive to conventional chemotherapy and radiation, and this patient is receiving this adjuvant therapy. So that was a diagnosis, metastatic pleomorphic xanthoastrocytoma.
Sorry. So I'm David, I'm with the PGY2s. I'll be giving grand rounds today, and I want to spend my time discussing cerebral vasospasm. I wanted to go into a dive about the history, management practices, and recent trials that were done on how to manage cerebral vasospasm. So, brief overview, we're going to go over the history, diagnosis, what the pathogenic findings tend to be. It's something that is an ongoing focus of investigation, something that I was interested in, and then just a review on management and controversies within the literature. So starting with the history, we've discussed this a couple times this year, but early descriptions of aneurysmal subarachnoid hemorrhage date back to as early as Hippocrates. It's always been described as a severe sudden onset of neurological insult that was originally considered to be a sudden onset pain in the head and followed by a stuporous coma. So Hippocrates describes this in 400 in aphorisms. But we progress a few centuries, and then we start seeing post-mortem cadaveric dissections demonstrating early evidence of aneurysmal dilation. So in the 1760s in Italy, we start seeing descriptions of the posterior carotids having these dilatations. And then Francisci Buemi, actually in 1765, publishes the first post-mortem evidence of a ruptured cavernous carotid aneurysm in a patient who also presented with a sudden onset headache and died a couple of days later. But it's really not until 1810 where aneurysmal subarachnoid hemorrhage begins to be considered as a clinical entity. And it starts with John Blackhall, who was a physician out in London, who describes a ruptured basilar aneurysm in the Swedish crown prince. Interestingly enough, that the death of that crown prince set in line the modern Swedish monarchy. And that was considered to be a pretty seminal event, both in terms of geopolitics within Europe, as well as within the evolution of medicine. Now, when we focus a little bit more on the idea of vasoconstriction and neurologic changes after a bleed event, we again focus on the 18th and 19th centuries, and it starts in Italy with a physician named Giovanni Lencisi, who characterized peripheral vasculature as having a phenomenon that it could spasm on its own. And he states that this idea of spasm causes a proximal pressure increase within the coronary vessels in the setting of ischemia. And he suggests that there might be an early role for the nervous system that innervates these vessels to cause these sorts of findings. Now, in 1813, John Hunter is evaluating the idea of vasospasm in the setting of trauma and providing descriptions of what vasculature looks like from an anatomic basis, and describes three possible states for a blood vessel to exist in. One is the natural state or a resting state, which is congruent to diastole. Second is the stretch state, so systole. And then finally, third, he describes as a contracted state that comes from the inherent muscular power of the blood vessel itself, and that's in the setting of mechanical trauma. But we go forward about 40 years, and William Gull, another physician in London, describes the case report of a 30-year-old woman who had a sudden onset headache and right hemibody weakness, was obtunded, but progressively improved by about day 4 after the event. But on day 5, she suddenly deteriorates and passes. On autopsy at the time, they found that she did have left hemispheric softening consistent with evidence of an infarct, as well as known subarachnoid blood and 2 MCA aneurysms. This really was the first case report of something like a delayed cerebral ischemia event in the setting of aneurysmal subarachnoid hemorrhage. Now, we enter into the 20th century and we start going into the idea of visualizing these events, not just characterizing them in case reports. So we start in 1925 in England, where Howard Florey begins to describe the idea using microscopic observation of feline arteries, and sees that they have vasoconstriction in response to not just mechanical stimulation, but chemical and electrical stimulation as well. And then in 1927, Egas Moniz in Portugal invents the angiogram. He would go on to win the Nobel Prize for this. And he uses 25% sodium iodide contrast to basically visualize the cerebral vasculature in cadavers in patients as well. So over here on the top right, what we see is a cadaveric angiogram. And this was actually the first specimen that he injected. On the bottom, in what's labeled figure C, is the first live patient. The live patient angiogram done in 1927, which he eventually published. Now, in 1949, we go forward a little bit more, and now we start getting more definitive descriptions of the idea of TIAs and strokes following angiographic evidence and cadaveric evidence of vasospasm. And E. Graham Robertson out of Australia basically theorizes that this ischemia is a transient event that occurs because in his dissections, he notes a profound absence of any type of permanent occlusion or embolus within the blood vessels of patients who had ruptured aneurysms but died of stroke-like symptoms, which starts positing the idea that maybe there's an entity called vasospasm, or at least delayed cerebral ischemia. But realistically, the word vasospasm isn't used until 1951 in Syracuse by Arthur Ecker. And at the time, he describes a case series of 6 patients who all underwent angiograms after having ruptured aneurysms. And he notes that within 23 days of hemorrhage, they had spasm that was reversible. So you see on the figure on the right, within the red circles, you have spasming blood vessels in 2 patients that were then restored. And at the time, he speculates that spasm could be a physiologic response to aneurysmal rupture as a way of the body protecting itself from blood loss. But he does posit that this could cause a secondary ischemic event. Now, from the 50s to the 80s, there was a lot of controversy in the literature on what spasm was, when to operate. And prior to the 1950s, aneurysm surgery, if done, was done even on days 7 to 10, what we now conventionally know is peak spasm window. And the initial angiographic evidence of vasospasm was attributed to a post-surgical complication rather than a post-hemorrhagic complication. Essentially, it was described as a neurosurgeon-created entity. Now, in 1965, though, we start seeing actual laboratory evidence of induced vasospasm in the setting of blood injections. So Francis Eklund at Lenox Hill Hospital injects fresh blood into the subarachnoid and intrathecal spaces for primates and notes that the cerebral arteries constrict profoundly in response to this. So we start seeing an increase at this point onwards on research into vasospasm and how to prevent it, given that it has a significant morbidity and mortality. And really the 1970s were the turning point for a lot of this. So in 1972, the vasospasm meetings were held in Jackson, Mississippi, hosted by Robert Smith out of the University of Mississippi. And really, these were academic conferences that were used to describe pharmacotherapies and the basic science underlying the study of vascular responses in the setting of subarachnoid hemorrhage. So Robert Smith's body of literature at the time used electron microscopy to demonstrate that blood vessels had structural alterations immediately after aneurysmal rupture that worsened within 2 days. And James Robertson, one of the other co-hosts for these meetings, used clinical evidence, or pharmacologic evidence rather, to have NSAIDs administered to a lot of these canines that had induced spasm, and he showed that there was a response, an improvement, which began the early literature investigating the idea that vasospasm was a pro-inflammatory state, which is something I'm going to talk about a little bit. Now, concurrently in 1972, outside of Jackson in Princeton, New Jersey, there was an academic conference that was held that was called the Princeton Conference on Vasospasm, where Clark Millikan, a neurologist out of the Mayo Clinic, began arguing that there was no clinical presentation that was consistent with angiographic spasm, that spasm had no effect on mortality, and ultimately that there was no relationship between surgical complications and vasospasm. Now, to a large extent, none of these things are true, and it contended with opinions of a lot of leading neurosurgeons at the time, including Thor Sunt out of Mayo Clinic and Dr. Drake, who posited that vasospasm was a post-aneurysmal entity that caused infarcts and was not secondary to interventions, but a byproduct of actual blood breakdown. But really, in my opinion, the strongest contributions to the study of vasospasm came from Charles Fisher out of Harvard. So in 1977, he provides the first definitive published case series on delayed cerebral ischemia and characterizes the time course that to this day remains true. So in that 1977 publication, Dr. Fisher discusses the idea that it develops 3 to 13 days after a sentinel bleed event, peaking around day 8, and that it's a reversible entity. He also notes the idea that there might be a disconnect between what is angiographic vasospasm versus what is clinical vasospasm, and states that angiographic spasm has to be severe enough to induce ischemia. And he starts correlating this to the severity of a bleed. In 1980, this later observation is published, and he begins developing what we now know as the Fisher grade. And he utilizes printed CT scans to define the relationship between the extent of subarachnoid hemorrhage and the later development of vasospasm. So he, in that paper, posits the idea that spasm is frequently directly related to clot location and volume, and the distribution of ischemic events is going to correlate to where that clot was. He also notes that every patient at the time who had vasospasm manifested a localizing syndrome that was consistent with ischemia, either transient or, in its most severe cases, permanent. Now, concomitantly, we have treatment advances going on after in 1970 as well. So in Germany at the time, Bayer Pharmaceuticals and a pharmacologist named Albert Fleckenstein discovered the idea of calcium channel blockers and began knowing that these medications are able to have vasodilation. That sets up a lot of the research that went into creating what would now be nimodipine, which was approved in 1988, which I'll get to in just a second. But in 1976, William Hunt out of Ohio State also began positing the idea that maybe we can treat these entities from a critical care perspective. And he describes the concept of hyperperfusion as a way of reversing ischemic symptoms. So he reports a case series of patients who had aneurysmal subarachnoid hemorrhage and vasospasm, and found that administering IV fluids and in some cases blood pressure augmentation allowed for reversal of these ischemic symptoms. But it wasn't until much later that the actual therapeutic paper on Triple H therapy was published, and I'll get to that a little bit later. But in 1983, Yuri Zubkov out of Russia publishes the first evidence of a balloon angioplasty for treating angiographic vasospasm. Now, he doesn't publish a case series, so the attribution of the first clinical series on balloon angioplasty doesn't happen until later in the 1980s out of UCSF. But this really was the first seminal event within neuroendovascular interventions for this clinical entity. In 1988, the US FDA approved nifedipine and nimodipine for reducing the effect of spasm in causing cerebral ischemia and poor outcomes. But even at that time, it was known that the medication didn't actually treat spastic vessels. It treated the ultimate clinical outcome for these patients. And this is something that I'm going to get to a little bit later when we discuss treatment modalities. So now that we've said the word a few times, we have to come to a point of defining what vasospasm is. So vasospasm is a focal or diffuse temporary narrowing of cerebral arterial caliber, secondary to smooth muscle contraction within the vascular wall. And really it gets divided into two clinical entities, one being clinical or symptomatic vasospasm, which manifests with anything from confusion to a decreased level of consciousness or focal neurologic deficits. It's also termed delayed ischemic neurological deficit within a lot of the literature now. And the second entity is radiographic vasospasm. So arterial narrowing that's evident on angiogram, either invasive or done via CT or MR. And it's shown through diminished contrast transit and filling. But over time, we start seeing that vasospasm is a delayed entity. So after a subarachnoid hemorrhage, we really have two types of ischemic events that can occur. One's within the acute phase, so 0 to 72 hours after the rupture of the aneurysm. And the literature now is transitioning towards describing this entity as early brain injury. It occurs from direct mechanical damage to brain tissue from the hemorrhage itself, but also the immediate pathophysiologic cascade that's responding to the acute bleed. So this includes things such as increases in ICP, reductions in cerebral blood flow, microcirculatory spasm and global ischemia, as well as neural injury, hydrocephalus, and cerebral edema. But the subacute phase is what we now clinically always refer to as vasospasm. And this is increasingly termed delayed cerebral ischemia because it's an entity that includes ideas beyond or clinical phenomena beyond vasospasm itself. So in this case, this happens anywhere from 72 hours to 3 weeks post-hemorrhage. And it's clinically defined now as a focal neurologic impairment or a 2-point GCS decline for at least 1 hour that can't be attributable to the aneurysmal rupture or to the treatment of the aneurysm itself. And this is a secondary deterioration process that can include vasospasm, microthromboemboli, cortical spreading and seizures, dysautonomia from thalamic injury, as well as ongoing systemic inflammation. So the clinical presentation of vasospasm is something we're all familiar with, but just review very quickly. It's a constellation of fluctuating or progressive symptoms that have gradual onset. So a lot of these symptoms can be either non-focal or focal. The non-focal symptoms can be progressive worsening headaches, meningismus, disorientation, obtundation, or an increase in hypertension as the body responds to this to increase cerebral perfusion. Other focal signs and symptoms include an ischemic syndrome. So you can have an ACA syndrome in the case of ACOM aneurysms that includes cognitive deficits, abulia, reflex disinhibition, drowsiness, or even urinary incontinence. Or you can have a classical MCA syndrome, which includes hemiparesis, monoparesis, aphasia, or in non-dominant hemispheres, apractic nausea. So the most common infarct patterns include single cortical infarcts, like I mentioned earlier, or multiple widespread cortical and subcortical infarcts, which would be diffuse vasospasm and can be a clinically deadly entity. Now, these symptoms obviously worsen with antihypertensive therapy as you drop cerebral perfusion pressure, and this is something we're going to discuss a little bit later. But the severity of vasospasm can range from a mild reversible dysfunction to severe permanent deficits and fatality. And approximately 10% of those patients can demonstrate sudden deterioration. So the time course is now pretty well defined, and it can really shape management both of the vasospasm itself as well as treating the aneurysm. So post-bleed days 3 through 14 are the highest risk period for vasospasm, with peak spasm window being between days 6 to 8. It almost never occurs prior to day 3, and clinical vasospasm itself resolves by around 2 weeks after hemorrhage, but can occur as late as day 20. But it's to note that radiographic and clinical vasospasm don't have identical incidence. So radiographic spasm can occur in up to 70% of patients who can get a CT or a CTA done that shows some amount of vascular caliber reduction on the angiogram, but they're clinically doing okay. It rarely occurs before day 4 and it peaks around day 7. Clinical spasms can occur over a similar time period, but only 20 to 30% of the patients who show actual evidence of vasospasm on a CT angiogram or a diagnostic angio are going to manifest clinical spasm. This difference more than likely is explained by the adequacy of collaterals, as well as the penumbra that is associated with the active vessel. If you can hyperperfuse automatically and auto-regulate yourself, you're not going to have a clinical syndrome following whatever radiographic evidence of spasm that you have. And it's just to note that not all subarachnoids will develop vasospasm, and that vasospasm can be an independent entity that occurs outside of aneurysmal subarachnoid hemorrhage. And it's been observed in things ranging from meningitis, tumor resections, or non-aneurysmal subarachnoid hemorrhage. So we go a little bit into the epidemiology of vasospasm events, and we note that there are clinical and non-clinical risk factors that are related to it. So non-clinical risk factors include increased age, active tobacco use, which is an independent risk factor, pre-existing hypertension, as well as hyperglycemia. And then the clinical risk factors from subarachnoid bleeds include clot burden of the fissure grade itself. The use of antifibrinolytic therapy to stabilize the aneurysm dome actually increases the risk of vasospasm, as well as a correlation that exists with the Hunt Hess grade. However, there's no consistent evidence on what vasospasm incidence rates are when compared to the method of initial treatment of an aneurysm. So between surgical clipping or endovascular intervention, there's no defined risk difference on whether someone will develop vasospasm or not. So we go into the idea now of, how do we predict vasospasm in patients? And we refer back to Dr. Fisher's paper from 1980, which showed the direct comparison between the severity of subarachnoid hemorrhage on CT scans and the incidence of vasospasm. So in a 47 patient case series, he had CTs performed within 5 days of subarachnoid hemorrhage and an angiogram that occurred between post-bleed days 7 to 17. And at the time, he developed a grading criteria from 1 to 4 that defined what the subarachnoid hemorrhage looked like on the printed CT scan. Grade 1 being no blood, grade 2 being less than 1 millimeter thick in the vertical dimension or diffuse deposition, grade 3 being a localized clot that was more than 1 millimeter in the vertical dimension, and the grade 4 being diffuse or with the presence of ICH or IVH. And on the angiograms, he defined the vasospasm according to their severity over three clinical grades, A being none, and C being the most severe, and then B being an intermediate between the two. Now, for the severity, he defined reductions in caliber according to the blood vessel and its proximity to the ICA, or the proximity to the ICA or the basilar. So in this case, M1 and A1 had less than 1 millimeter vessel size, whereas M2 and A2 had less than 0.5 millimeter vessel size. And his paper, he basically finds that the most severe vasospasm occurred in patients that had the highest grade on the CT scans, which is something we now refer to pretty actively. And you say that the critical finding was that the largest clot burden, so a fissure grade 3, corresponded to the highest incidence of severe spasm. And in the paper, he describes it as the only important etiological risk factor. His implications in his discussion section for that paper were that, for therapy at the time, you could directly deal with a spasmogenic blood clot, including evacuation of the hematoma during surgery, arterial irrigation, or administration of adrenocorticotropic hormone, which is something that has generally fallen out of practice at this point. He also at the time discussed the idea of prophylactic vasodilation to treat vasospasm and consideration of bypass, which is not really something that we do for vasospasm now, but he posits the idea that this is a reversible entity and that it could be treated. But we take one step forward and go to 2001, where Klassen actually revisits the Fisher grade and wants to spend more time accounting for the idea of what intraventricular and intraparenchymal blood clot contributes towards vasospasm risk. So in their case series of 220, or in their case series of 276 patients who had CTs done within 3 days of symptom onset, they diagnosed delayed cerebral ischemia according to both clinical deterioration or a CT scan that showed infarcts, but it wasn't necessary that these patients had angiography or TCDs done. And they used logistical regression to ultimately construct 6 models for rating the CT scans in relation to the severity of delayed cerebral ischemia. The primary variable at the time was that they wanted to find if there was complete filling of one or more cisterns or fissures with subarachnoid hemorrhage. And the secondary variable was that if they had unilateral or bilateral IVH with or without ICH. And they compared the predictive values of all 6 models. And the one they ended up with was one that created 5 grades from 0 to 4, with grades 0 to 1 being defined as a low risk of vasospasm, grades 2 to 3 as an intermediate risk, and grade 4 as the highest risk. So in these cases, they divided all the grades according to both the severity of the subarachnoid hemorrhage itself, either minimal or thin, or filling a cistern, and whether or not there was bilateral IVH in the lateral ventricles. And on this scale, they actually showed that the frequency of delayed cerebral ischemia and infarction was commensurate to both the severity of the subarachnoid as well as the presence of IVH. And they contended that if you compared that same 276 patient population's Fisher grade, their what they termed the modified Fisher scale or the Klassen scale demonstrated a prediction of superiority when you looked over a logistical regression. And in the 1980 paper, Dr. Fisher didn't follow the long-term outcomes of his vasospasm patients, but Klassen utilized a modified Rankin score to show that the 3-month outcome was actually worse in patients who had delayed cerebral ischemia and survived their subarachnoid hemorrhage, which is something that is intuitive. Ultimately, which score you use doesn't make a huge difference because the grading criteria demonstrates the same baseline finding, which is to say that the more severe your subarachnoid hemorrhage is, or the more severe your IVH is, the higher risk you are of developing vasospasm in the long term, which leads us towards the idea of how you diagnose vasospasm. So one thing to consider in this case is looking at vasospasm as a combination of clinical assessment and auxiliary testing. So in these sorts of settings, we have to exclude other etiologies before we determine something to be a vasospasm-related event if we don't have other imaging available to us at the time. So we have to rule out entities such as rebleeds, hydrocephalus, seizures, edema, or toxic and metabolic encephalopathy. And ultimately, there are both radiographic and bedside modalities for diagnosing vasospasm. So whether visualize the artery using something like an invasive or a non-invasive angiogram, or we evaluate the secondary ischemic penumbra using perfusion imaging, or we use a bedside modality, so a transcranial Doppler or a continuous EEG. And really today, I wanted to focus on the latter two. So transcranial Dopplers are non-invasive point-of-care modalities for inferencing cerebral blood flow dynamics as a function of velocity. And originally they were described in 1982 by Rune Aslid. And the technique for doing a TCD is using a 2 megahertz probe that transmits pulsed sound waves through known windows that reflect the thinnest portions of bone along the calvarium in the direction of major intracranial vessels. So the probe emits sound waves contact moving red blood cells and reflect back to the TCD probe. And this goes back to physics on the idea of Doppler shift. And it's directly related to both flow velocity and the direction of blood flow. And TCDs don't just capture a single velocity, but a whole spectrum of them. And they plot them as a waveform similar to something like an arterial waveform on peripheral Dopplers as well. However, this occurs at a lower sonication frequency. The acoustic windows that are used in getting a TCD include 4 primary windows that are done, and they're regions of thin bone which allow optimal targeting for blood vessels. So the transtemporal window allows for better visualization of the ICA, MCA, and anterior cerebral artery. The suboccipital window allows better visualization of the posterior circulation. And a transorbital window allows for assessment of both the carotid siphon as well as the ophthalmic artery. And the submandibular window, which is often used, allows evaluation of the distal ICA. And it's a note that TCDs demonstrate physiologic variability. So it includes demographics, what the hematocrit of the patient is, what the carbon dioxide level of the patient is on an EBG, as well as the temperature of the patient. So ultimately, the physics of transcranial Dopplers are the physics of flow dynamics. And we know that flow is equivalent to the velocity times the cross-sectional area of the blood vessel. So at constant flow, or when you have constant flow being preserved, velocity is inversely proportional to the cross-sectional area. Now, in a setting of cerebral vasospasm, TCD velocities actually demonstrate an uptrend because the cross-sectional area decreases. And this can occur often 24 to 48 hours prior to clinical symptoms. The velocities that are seen on a TCD can ultimately help grade the severity of the spasm. So less than 120 centimeters a second is graded as mild spasm, 120 to 200 is moderate, and greater than 200 is severe. And the strongest literature sensitivity for vasospasm is for mild and severe velocities. It's to note that there's also reference to a Lindegaard ratio, which helps distinguish between vasospasm and alternate etiologies that affect blood vessels themselves outside of the intracranial circulation. So the Lindegaard ratio is a ratio of the MCA to the ipsilateral extracranial ICA's mean velocities. And the rationale behind the Lindegaard ratio is that that factors affecting blood flow, so hyperemic blood vessels, hypertension, and volume status will affect both the extracranial ICA as well as the MCA, producing a lower Lindegaard ratio, while vasospasm will uniquely affect the MCA, producing a higher Lindegaard ratio. And this helps provide another prediction for what vasospasm severity looks like. Another area of literature that's been ongoing within neurocritical care is using continuous EEG to predict vasospasm occurrence. Now, there's only a small amount of papers from the 1990s that have provided published evidence on this, and it's an ongoing area of research. But the short of it is that continuous EEG has demonstrated organized reductions in waveforms and amplitude that precedes the onset of spasm, and it's consistent with the idea that you have progressive ischemic events going on. So Vespo publishes the first paper on this in 1997, and he describes that there's a variability in the relative alpha value. So it's defined as the decrease in the alpha wave, and this is a predictor of vasospasm occurrence. So excellent. So if you look at the figure on the top right, excellent relative alpha variability on the fourth image on the top right basically is something that is a good clinical response, whereas poor relative alpha variability suggests the impending vasospasm. So in their study of 32 patients who had aneurysmal subarachnoids and had 8 electrode EEGs connected within their neuro ICU, they graded across 1 to 4 scales and showed that decreased relative alpha variability, so a drop from something like 4 to 2 or 3 to 1, especially by 2 grades or more, preceded vasospasm by often 2 to 3 days. And it correlated with globally decreased blood flow and signs of ischemia. And this is something that they publish across patients, as you see on the figure on the bottom right. Elsewhere, other publications have shown that you get decrease in the EEG amplitude across all frequencies, so a measure known as total power, as an early electrophysiological correlate for delayed cerebral ischemia. It's noted that not all patients, though, would necessarily be suited to get continuous EEG monitoring after an aneurysmal subarachnoid hemorrhage, both because the severity of this vasospasm can be predicted either clinically or with something like a TCD, which is far less invasive. So following the idea of knowing how to diagnose vasospasm, we try to understand from a basic science angle, what does vasospasm look like in vivo or on a path slide? And ultimately, the conclusion that gets drawn is that even though the cause for vasospasm is uniquely unknown, it's theorized that it's a local inflammation-mediated cascade that involves both restructuring of the blood vessel wall, loss of physiologically normal autoregulation, and impaired contractility of the smooth muscle. Ultimately, vasospasm is an issue of smooth muscle contraction that's mediated by breakdown products from the blood, as well as a nervous deregulation. And what I mean by that is you can have either impaired vasodilation, excess vasoconstriction, or the nervi vasorum undergoes changes that include deregulation of vasoconstrictor tone, a dampened vasodilatory response, or sympathetic hyperactivity from the hypothalamus injury that accompanies most subarachnoid hemorrhages. The extension of this inflammatory cascade from large subarachnoid vessels to the pia helps generate what is symptomatic ischemia, and can also be a rationale for explaining why patients who have radiographic evidence of spasm in larger vessels may not have delayed cerebral ischemia that's evident clinically. So we look at what we look into a study of what the small molecule mediators of vasospasm are, and we note that, like a lot of systemic inflammation, it's a multifactorial cascade that accompanies blood breakdown. Now, the initial cascade that occurs because extravasated red blood cells in the subarachnoid space will release extracorpuscular hemoglobin, which is known to be a toxic pro-inflammatory molecule. that'll bind up free haptoglobin, which binds to hemoglobin within systemic circulation as well, to form these hemoglobin haptoglobin complexes. Additionally, though, that free hemoglobin within the subarachnoid and intrathecal space will induce upregulation of a lot of cellular adhesion molecules within the exposed arterial lumen and the injured endothelium. And there are really three categories of molecules that we care about here. Selectins are molecules that promote the adhesion of leukocytes to the endothelium wall. Integrins bind circulating immunoglobulins. They increase wall adhesion, and they arrest migration to induce white blood cell migration outside of the blood vessel itself. And then finally, you get a family of immunoglobulin superproteins, including one referenced as ICAM1, which additionally helps promote extravasation on the end of the blood vessel wall and at the site of rupture. Now, through this process of hemoglobin inducing this upregulation, these leukocytes exit into the subarachnoid space, and they'll engage those haptoglobin hemoglobin complexes to take in all the hemoglobin as well as the red blood cells that had come out. This will be broken down into bilirubin, which will be the first small molecule blood product that can help induce vasospasm. But the second thing is that these leukocytes end up being trapped within the intrathecal space and will undergo apoptosis, and in that process release additional inflammatory molecules, so endothelins, free radicals, and cytokines. The levels of each of these markers have been shown in laboratory studies to be elevated in CSF and blood in the setting of spasm. So here's a description from Judy Wang's group out of Johns Hopkins that shows the process that I just described, both in terms of what happens within the blood vessel wall as well as within the subarachnoid space and with blood vessels. Now, the first thing we come across is oxyhemoglobin and how the bilirubin products will impact vasospasm. So the oxidation of free hemoglobin and bilirubin breakdown will advance inflammation both within the intrathecal space as well as within the endothelium. So oxidized hemoglobin ultimately has a higher binding affinity for nitric oxide. Nitric oxide is a known vasodilator, and what happens in this setting is that it'll reduce the vasodilatory response and the permeability of the endothelium. So nitric oxide is normally synthesized in response to shear stress and metabolic dysfunction. And nitrite levels are known to drop within aneurysmal subarachnoid hemorrhage. So what they found is that administering nitric oxide in rodents that are undergoing induced vasospasm actually prevented or ameliorated the symptoms. And realistically, what oxyhemoglobin also will do is increase the level of intracellular calcium and inositol triphosphate within the blood vessel wall. And the intracellular calcium is the primary mediator for an increase in myogenic tone. So that's one aspect of how small molecules will mediate vasospasm from blood breakdown. But the second one is bilirubin itself. So like I mentioned earlier, white blood cells would take up the hemoglobin that's within the subarachnoid space and break it down, and bilirubin will get oxidized into bilirubin oxidization products, which are also known to be pro-inflammatory. In this case, what we've seen is that box administration in rodents is sufficient to induce vasospasm, independent of in the setting of like vasospasm not being ongoing. The other mediators of vasospasm include molecules like endothelins. Now, when you have leukocytes undergoing apoptosis within the subarachnoid space, they release reactive oxygen species, cytokines, and endothelins. So endothelin 1 is a potent vasoconstrictor that acts on endothelin A receptors to increase, well, like I mentioned earlier, calcium influx and cause arterial narrowing. So it's released actually induced after you have oxyhemoglobin formation and the apoptosis cascade in white blood cells. And what we see is that with both of these white blood cells and neurons undergoing cell death, you start seeing the release of TNF alpha, interleukin 1, and it stimulates endothelin production from the blood vessel and causes release, which will then cause calcium influx into cells and vasoconstriction. The plasma and CSF levels of endothelin are noted to be higher in post-bleed days 8 to 14, which correlates with the initial nadir with the initial peak of vasospasm and the latter half of the vasospasm window. And the prevalence of this literature actually has led to some major clinical trials which tried to investigate the use of endothelin antagonists as a possible treatment for vasospasm. So the Conscious 1 trial done in 2008 was a phase 2 randomized clinical trial that was assessing the use of IV clazosentan, an endothelin A receptor agonist, in aneurysmal subarachnoid hemorrhage and vasospasm. They evaluated 413 patients and assessed whether there was a dose-dependent decrease. And they found one, a reduction in vasospasm from 66 to 23%. But they also noted a complication, a profile that included pulmonary edema, anemia, and hypotension. Now in CONSCIOUS 2, when they advanced the trial forward to evaluate whether you can have vasospasm treatment in patients who underwent surgical clipping, they looked at about 1,150 patients and looked at the 6-week morbidity and mortality. And ultimately, they found that actually compared to placebo, there was no difference in patients who had received clazosentan, but they did note the same complications, pulmonary edema, anemia, and hypotension. There's another phase 3 randomized trial called CONSCIOUS 3 that evaluated patients who underwent endovascular therapy, but it was terminated early, so the outcomes from this trial are unknown. But similarly, the overwhelming evidence right now suggests that endothelin A antagonists, even though they've been useful within the lab, haven't demonstrated similar use in the setting of clinical trials. So the other thing we want to look at is what other types of changes can occur from an inflammatory standpoint. And what we see is you can have microthromboembolisms, emboli forming within the blood vessel wall in the setting of this inflammation. And this usually can start within 2 days of aneurysmal subarachnoid hemorrhage and continue until a week after the initial rupture event. Multiple factors can incite this, including, like I mentioned earlier, decreases in nitric oxide, increased expression of prothrombotic factors, so things like platelet activated factors like thromboxane A2, the presence of serotonin, ADP, as well as P-selectin. And what results here is you get platelet aggravation within the microvasculature and multifocal clot formation. So within the histology that originally came out of Mississippi in the 1970s and the electron microscopy studies that I mentioned, what we see is that you have a time course of spasm that correlates to changes in the blood vessel wall. And that's evident on histology. So in the acute phase, so days 1 through 8 after the initial event, you can have endothelial swelling and vacuole formation, as well as breakdown of the blood arterial wall barrier within the intima. And that's noted on that top square on the image on the left. The next thing you see is muscle necrosis and smooth muscle breakdown within the media. That's that bottom square on the image on the left as well. And increased inflammatory cells present within the adventitia of blood vessels. You see the delayed response a little bit later, and you see that you're now going to have much more fibrosis and scarring within the intima. And what you see on the image on the right, on the bottom right there, is that beneath the intima, you have subintimal fibrosis and smooth muscle proliferation. So you actually get progressive vasoconstriction in this case that correlates to the time course of vasospasm onset being most severe around 1 week post aneurysm rupture. So now we do dwell more on the idea of how do we manage vasospasm, both either prophylactically or clinically when it's occurred. And the fundamental question within the literature, both neurosurgical and within neurocritical care, is 1, can vasospasm be prevented pharmacologically? Or 2, when it does occur, how can it be treated, either using innate physiologic principles, pharmacotherapy, or direct mechanical intervention? And ultimately, what we find is that there's a relative paucity of what are definitive clinical trials, but the literature base is constantly evolving and figuring out what works and what doesn't work. Now, animal trials have demonstrated an extensive array of small molecules that suggested some promise. If we're able to induce vasospasm within rats, cats, dogs, and primates, there have been molecules that are also investigated to treat that vasospasm. And there have been trial interventions as well that are done. So things like clot evacuations and intrathecal injections. But the problem with these interventions is that they don't necessarily translate into safe, ethical, or common sense human practice that can be done within modern hospital systems. So the first set of treatments that we look at are prevention of vasospasm. And really one of the most common medications that's given in our ICUs now is nimodipine. So just to review, calcium influx is a primary mediator of smooth muscle contraction. Like I said earlier, calcium channel blockers have been known since the 1960s to have vasodilatory effects and are neuroprotective. And the literature base for this includes traditional calcium channel blockers, so nifedipine and nimodipine, but it's also magnesium sulfate, which is an area of increasing study. And Picard, actually out of England, publishes the first study in 1989, which was a prospective randomized clinical trial that evaluated the use of nimodipine in preventing ischemia and provided what is the early framework for the current treatment paradigm for giving nimodipine to patients who have subarachnoids. And in about 550 patients, they noted that administering nimodipine 60 milligrams every 4 hours for 3 weeks showed a reduction in the incidence of cerebral infarction and poor functional outcomes. Now, I referenced magnesium sulfate just a little while ago, and unfortunately, there was a phase 3 trial that was done out of China in 2010 called the IMASH trial, which investigated the use of magnesium sulfate infusion in subarachnoid patients, and it found no clinical benefit. Ultimately, though, what the big takeaway here is the use of nimodipine alone, not other calcium channel blockers or magnesium sulfate, is known to reduce poor functional outcome in secondary ischemic events, but it doesn't treat or prevent vasospasm directly. Patients who are getting Nematope will still develop vasospasm, but their likelihood of having a long-term poor functional outcome will be lower compared to patients who aren't receiving it. The second area of research within prevention therapy is what is the volume status of these patients, and can we prophylactically provide hyperdynamic therapy? And the evidence for this is that ultimately you want to go towards maintaining euvolemia to prevent vasospasm, but you don't necessarily want to do triple H therapy. And I'll cover the types of triple H therapy in just a second, but the paper for this comes out of Norway in 2001. It was a prospective randomized controlled trial that tried to use prophylactic Triple H therapy prior to the vasospasm window onset. So in 32 HUS 1 to 3 patients who underwent surgical clipping of their aneurysms, the study arm of 16 patients had D5NS and colloid plus or minus dopamine drips administered for hemodilution, hypertension, and hypervolemia. And this was compared to patients who were maintained with euvolemia until post-bleed day 12. And ultimately, they found that there was no clinical difference by day 12 or in 1 year clinical follow-up for the patients who were in the study arm. What they did note, though, was that the cost and the complication rate was higher for inducing hypertension preventatively in these patients. So right now, the overwhelming guideline is just to maintain euvolemia for preventing spasm, but things get a little bit murky when we go into treatment. I'll cover that in just a second. The other area of prevention and treatment research involves the use of statins. So we know that statins are HMG-CoA reductase inhibitors and are known to have anti-inflammatory properties, including reducing the amount of pro-inflammatory cytokines that are in circulation and inhibiting leukocyte integrin function. And Sang publishes a trial out of England in 2005 that was a phase 2 trial investigating the use of statins and reducing the incidence of vasospasm. And in 80 patients, they administered pravastatin for 40 milligrams every day for 2 weeks. And they reported pretty significant reductions in vasospasm, both generally and for severe vasospasm, as well as delayed ischemic events. But subsequent analyses show that in retrospect, there was actually no significant protective benefit or vasospasm prevention that occurred in inpatients who received statin therapy. And ultimately, the STASH trial that was published in 2014 was an international phase 3 trial that provided even more definitive evidence on this. So in 800 patients, they gave a stronger statin, simvastatin, for 40 milligrams every day for 3 weeks. So at twice the strength and for a longer duration than the Sang trial, and found that there's no difference for cerebral ischemia, length of stay, mortality, or long-term functional outcomes. So the literature generally is now falling away from the use of statins for vasospasm prevention. So now we gravitate towards the idea of treatment, and what was the conventional mainstay after the 1990s was the idea of Triple H therapy for treating vasospasm. So just to review, it was hypertension, hypervolemia, and hemodilution. And it was posited as a treatment mechanism during the postoperative period to help augment cerebral blood flow, given there was a high risk of ischemia because vasospasm closes off blood vessels. And Orgatano out of Illinois published this first paper in 1990. And in a 43 patient cohort, they utilized xenon 133 and inhalational perfusion imaging to basically, at time intervals, including admission, post-op, and during the postoperative period, look at whether or not there was a cerebral perfusion response to Triple H therapy. And the criteria that they used was they phlebotomized patients to maintain a hematocrit between 27 and 33% within the first 24 hours of presentation. They administered 5% albumin, D5 half NS with potassium at higher rates, and maintained a central venous pressure of 8 to 12 and systolic blood pressure of 130 to 150 in unclipped patients, or 150 to 175 in secured patients with a vasopressor augmentation or vasodilatory augmentation as necessary to get that goal. And they weaned therapy within 2 weeks based on the clinical response of the patient. What their findings were was that for 21 days, all of their patients had cerebral blood flow that was sustained with this therapy. And what they noticed was that between days 8 to 13, urine output actually substantially increased in patients requiring the addition of a vasopressin drip as well in order to prevent ischemia from setting on. And in their case series, 15 patients who had shown ischemia required blood pressure augmentation of up to 180 to 200. 2 patients in that entire series developed permanent neurologic deficits, and it was attributed to the idea where that they couldn't maintain their therapeutic goal. But realistically, the evidence base for this is now increasingly falling away or being redefined. So in the 2000s and 2010s, we've now had a subset analysis of Triple H therapy that parses out the individual benefits of the 3 components. And realistically, the big conclusion that gets drawn is the most impactful facet of Triple H therapy is actually induced hypertension, and generally speaking, avoiding hypotension or hypovolemia. So no large-scale randomized clinical trial or consistent evidence actually exists on the utilization of hemodilution or hypervolemia for maintaining cerebral blood flow. And in a systematic review that was done in 2010 of 11 studies that specifically looked at Triple H therapy incorporation, they found that hemodilution doesn't demonstrate significant cerebral blood flow increases independently. Hypervolemia similarly is very equivocal in its treatment. Hypertension, however, consistently will cause a cerebral blood flow increase, and it's known to be significant in one study that was originally actually published in 1986. So this consistent effect suggests that you want to have induced hypertension in patients that are undergoing vasospasm, and you want to maintain at minimum euvolemia and not have hypovolemia. So the class 1B evidence based off the most recent guidelines that were published in 2011 suggests that there's a pretty well-defined treatment protocol for hemodynamic augmentation. And ultimately, you want to continue crystalloid IV fluids to maintain euvolemia. And the general preference is for isotonic, so normal saline or lactate ringers or isolate if that's available, and maintain a hematocrit that's above 40%. And you can give colloid to maintain it within that realm as well. The big thing advised is avoiding transfusions of dextrans or starches because those they impair coagulation. So in the setting of an intracranial hemorrhage, this would be something that would be contraindicated. And for blood pressure augmentation, they actually endorse increasing the systolic blood pressure in 15% increments up to a maximum of about 200 to 220 millimeters of mercury, monitoring for cardiac ischemia and starting either inotropes or vasopressors as needed to help maintain these effects. The blood pressure augmentation evidence shows that it's actually less effective in patients who have a baseline hypertension because of their systemic response to an increase in blood pressure. And in patients who have cardiac comorbidities. And this correlates to the idea of what the complication profile would look like for someone who has a systolic blood pressure up to 220 that's artificially maintained within the ICU. You can have an increase in ICP and cerebral edema. You can have hemorrhagic conversion of infarct, pulmonary edema, or you can have a stress cardiomyopathy, which is something that aneurysm patients are already predisposed to due to autonomic deregulation from thalamic insults. And in some cases, you can have myocardial infarction, which is something we've occasionally seen in our ICU. Now, the other idea is if medical therapy fails, or if you have patients who are a cardiac mess and can't get artificially induced hypertension, how do you treat them? And there comes in the idea of endovascular intervention. And really, the 2 big mainstays right now include a balloon angioplasty versus intraarterial injections. So in 2008, they did an initial phase 2 randomized clinical trial to study the idea of a prophylactic intervention. So in a Fisher grade 3 patient who undergoes aneurysmal subarachnoid, can we do a prophylactic balloon angioplasty? And they looked at 175 patients who underwent angioplasty within 96 hours of presentation. And they actually found a non-significant decrease in the incidence of delayed ischemia. But the only significant finding in that paper was that those patients required fewer secondary interventions, so a rescue angioplasty. However, there was no overall risk reduction that was seen or long-term outcome. And this is also taking into account the fact that there is a complication profile with angio. 3 patients in that study actually had intraangio vessel rupture and required further intervention to treat that rupture. But the 2 primary mainstays, like I mentioned, are the use of intraarterial injections or balloon angioplasty. So in the former, you can inject papaverine, which is a cyclic AMP and GMP inhibitor, verapamil, which is a non-dihydropyridine calcium channel blocker, or nicardipine, which is a dihydropyridine calcium channel blocker for vasodilation. And Sam Cassell at UVA first describes this in 1992, where he publishes a case series of 12 patients who underwent papaverine infusions over an hour, and he saw angiographic evidence of vasospasm reversal in 8 of them, and was also able to use it as a rescue therapy in patients who had refractory vasospasm. Now, Higashida in 1989 publishes the first case series of using a balloon angioplasty in patients who are undergoing spasm out of UCSF. And in 13 patients, they used a novel silicone balloon to reopen blood vessels in patients anywhere from 15 to 73 years old, and about 70% of them had a return of neurologic function. But broadly speaking, right now, there's still a positive evidence on comparing the 2 modalities, but it does show overall that there's an improvement in vasodilation and recovery of neurologic function. There is no trial that has been done yet that shows superiority of one over the other, and it's something that can be judged clinically. Something to always consider, though, is also the risk of having a patient undergo endovascular intervention. This is something that has to be judged in comparison to medical therapy. So overall, then, what do we take away from this, right? Vasospasm remains a prevalent cause of morbidity and mortality in the setting of subarachnoid hemorrhage, and it's a fundamental component in the postoperative critical care of aneurysm patients. It can't be something that's overlooked, and it can't be something that's forgotten. The pathophysiology of this process is a complex, multifactorial cascade of both inflammatory responses, nervous system deregulation, and a secondary microangiopathy from thromboembolism formation. The diagnosis remains predominantly clinical, but we can use ancillary bedside testing like TCDs or neuroimaging to know when a patient is actively in spasm. And even though the clinical data are equivocal, they're increasingly trying to identify what are mainstays in treating delayed cerebral ischemia. So we know that nimodipine will improve outcomes while preventing worse outcomes of delayed cerebral ischemia, but won't treat spasm itself. BP augmentation and avoiding hypovolemia provide improved cerebral blood flow in patients who are undergoing spasm. And in patients who are either refractory or are clinically indicated, balloon angioplasty and intraarterial injections can help provide more definitive treatments as necessary. Ultimately, further research would need to be done to look at what the overall outcomes for each of these modalities are, and to assess small molecule therapies that aren't being translated effectively from the lab to the clinic. So ultimately, vasospasm is a very complex entity. It's very interesting to study, and it's something where the literature base is still growing and will continue growing over the next few years, both within neurosurgery and within critical care. And with that, I'll end my talk. Any questions?
Hi, Vivek. This is Ayham. Can you hear me?
Yeah, I can hear
you. Great talk. And the other thing I've used, recently for those that partially secured aneurysms or unsecured aneurysms, and you want to, you can't push the blood pressure much, during medical therapies, stellate ganglia block, to kind of relax that, sympathetic drive. There's some pilot data on that, but really, has not been studied really well systematically. But yeah, great job. And yeah, you should do a critical care fellowship. Great job.
Yeah, that was a great talk. I mean, I think a couple of things to think about are, what's coming along in vasospasm in terms of medical therapy and critical care. And there are some trials and studies going, like IA or intraventricular milrinone. Those studies have been pretty difficult because you need such a large number of patients to have enough power to show a clinical benefit. We saw that in the clausen-10 randomized clinical trials. I mean, we needed a huge number of patients, and as neurocritical care has been getting better, the incidence of vasospasm is actually going down. The second one, which, you know, in theory might have a bigger impact, is new endovascular technologies. So there are a number of new types of stents and things like that. So one things that people have been starting using is, I think we talked about is stent retrievers. The benefit of a stent retriever over balloon angioplasty is that it's easier to get into a small vessel. And we have 40 mm stent retrievers versus the balloons are much shorter. So instead of doing multiple angioplasties, you just do one opening of the stent retriever and then you retrieve it. The disadvantage is most of the stent retrievers have less radial force than a balloon. So you have a higher chance of needing to come back for another treatment, even though potentially it's safer. And there's a number of different types of sort of stent-like technology with adjustable openings that may, you know, prove to be a better option for some of these cases in the future. But great job.
Thank you.